Welcome, everybody. Rush University Medical Center Division of Nephrology Renal Biopsy Conference for October 12th, 2023. Today's CME activity code is 489611. This conference is being recorded. It'll be posted shortly on YouTube in our channel. Please subscribe to our channel, and anybody not on our mailing list, send us a direct message and we'll put you on the mailing list. As usual, we have nothing to disclose about this conference, and the patient identity is being preserved for confidentiality issues. So we have a great case today. It's going to be a lot of fun, and it's Dr. Whittier's case. So let's hand it over to Bill.
Cool,
Bill
thanks.
can walk us through the protocol. Thanks, Bill.
Sure. Yeah, we've got kind of an older gentleman who's 78. He's Irish descent. He came in for evaluation of progressive chronic kidney disease, and now it's stage 5. So he's got a history of BPH, arthritis, and bladder cancer. The bladder cancer, though, was several years ago, and it's been in remission, as well as long-term NSAID use from 2008 to 2018. During that time, mostly for his OA and some hip troubles and shoulder troubles, he used Aleve. He finally saw a nephrology, an outside nephrologist, in 2018, who did a workup and found that he had no obstruction, no hydronephrosis. He had a bland urine, and he had minimal proteinuria. Whenever it was checked, it was 350 to 750 milligrams per gram. And his creatinine at that time was 1.7. So this was around 2018. He was told to stop his NSAIDs, and he did. His creatinine actually got better to 1.5. But then after that, despite no further NSAIDs, it kind of slowly progressed up over the next 4 years to 2.0. So it's kind of slowly progressive CKD. In 2023, he underwent a hip replacement, which was completely uncomplicated, and his creatinine was at its baseline prior to surgery, and post-op, his creatinine was the same, about 2. But 1 month later, and just follow-up, he had increased to 2.7, and everybody was pretty surprised. They didn't really know why it went up in a month. When post-op, he was fine. He didn't have any new medications. Sometimes they can use NSAID creams and Voltaren gels, and there was none of that. He didn't use any other NSAIDs, no herbal supplements. They stopped his irbesartan just in case there was an issue there, and they started him on nifedipine. But then the next month, his creatinine had gone up to 3.4. So it's kind of going up a little faster than his previous stuff. So his repeat ultrasound was without obstruction. Again, his urinalysis remained bland. This time it had some glycosuria and low-level proteinuria again, no blood. His blood pressures were normal. He was completely asymptomatic except of a little bit of mild fatigue, but that wasn't limiting his daily activities. He's still able to go and golf and do everything he wanted. His appetite was great. No issues in urinary habits or anything like that. So his past medical history is CKD, hypertension, the bladder cancer that I mentioned, but 6 months ago, he'd had a cysto and he was in remission, and BPH. He had some surgeries which are really kind of irrelevant, a colonoscopy, appendectomy, and so on. The hip surgery was the most recent one. His irbesartan was stopped about a month ago. He's been on nifedipine. His blood pressure control on that agent with the switch has been the same. He's on tamsulosin and an aspirin. Nothing in the family and nothing really social. His exam was really unremarkable. He was in no acute distress. His lungs were clear, no edema, no real joint issues. He had some OA of the fingers that I didn't put in there, but nothing crazy. So for his labs, I just put a serum creatinine trend in here because we have a lot of data on him. He went in 2014, he was 1.02. A year later, 1.3. A year later, 1.5. 2 years later, 1.7, and that's when he saw the nephrologist who said no NSAIDs. Went down to 1.5 and 1.44 later. And then kind of slowly went up 1.6, 1.8, and 2.07. And again, prior to his surgery, he was around 1.9 or 2. His CBC was unremarkable. This is now current CBC. He had a little mild anemia. He was not iron deficient. His lab showed that his potassium was 4.9, his chloride 114, bicarb was 17, creatinine was up to 3.6. It had kind of stabilized in the following month that it got to see me. He went up after surgery and then went 3.6 and then 3.6 again. His albumin was great at 4.6. no LFT abnormalities. His serologic workup was completely normal or negative, complements normal. His SIP and UIP were without a monoclonal protein. His serum free light ratio was 1.8, consistent with CKD. His urinalysis had 1+ protein. It had trace glucose with a normal serum glucose. He had negative blood and no cells. His urinalysis or urine PC and AC were his urine total protein on ratio was 648, and he had a urine albumin to creatinine ratio of 149. His ultrasound was essentially fine, normal, and we got him ready for a kidney biopsy.
Great. Any questions for Dr. Whittier?
Bill, Mario, do you have an EGFR or cystatin C on this gentleman?
Yeah, his EGFR right now is 16. Let's see, I think I put his weight and height in there too. He was kind of a normal sized older guy, maybe a little on the heavier side, but yeah, he's now about 17.
Any consanguinity in the background of this family, in this person?
It's a good question, and I don't know.
The reason
Wow.
I ask is that I strangely am fixated on the Irish descent here, because in Ireland there is a lot of chronic interstitial nephritis that tends to be familial. I just wondered if that had anything to do with this person's possible disease. That was the reason for the question.
I know his 2 children do not have any issues, but I don't know about his, brothers, sisters, and older people in his family.
Okay.
It's really funny because I was on a recent other conference. Canars, Dr. Javari's has a conference every now and then, and his case started with a Punjab individual, and that immediately start screaming out to me for a similar kind of thing. And so it's anytime now I see if it's Asian, it doesn't really count, but Irish, yeah, it's kind of interesting. So yeah, we'll have to see if that has any relevance or not. But yeah, we have a poll to start with. So poll number 1. So be honest about this, everybody. Number 1, would you do nothing? This patient's just too old and the disease is too chronic. We just learned he has an EGFR of under 20. Would you do genetic testing, or would you do a renal biopsy? You have one choice here. Nothing, just treat him, we'll follow him. 2, genetic testing, or 3, do a renal biopsy.
Is Dr. Glassock allowed to vote?
Actually, none of the
No,
none of the co-hosts can vote.
none of the hosts can vote.
I know, I was just kidding.
Hey, Bill, there was a question in the chat. Did the patient get any chemotherapy at all during his course of bladder cancer?
No, he just had resections.
Okay.
And no recent COVID.
Correct. No recent COVID. Thank you.
Yeah. Certainly the chemos are really good. And sometimes COVID has become so ubiquitous now we don't even think of it. I had a case the other day where it just kind of flew over my head, not even thinking about it. But that's still a big cause of problems. Okay, so we can show their poll here. In spite of my begging people, and obviously this is renal biopsy conference, 80% said they would do a renal biopsy, 7% they would do genetic testing off the bat, and 15% said do nothing, he's too old, too chronic. Well, I got news for you. We didn't do a renal biopsy, so we'll see you guys next week with a new case.
have a good week, everybody. Enjoy
Have
the
a good
holiday.
week, everybody. No,
You can do that for
actually,
April Fools too.
I lied, but next slide. So, Casey, what are your thoughts about all this? Oh, by the way, we have a guest speaker, but I don't think he's. It's about 7 or 8 p.m. where he's at. Dr. Corbett's in France, and so I figure he's got about 2 bottles of wine in him. So I'm not going to call on him. But welcome, Steve. We're glad you made it. Casey, you
Portugal.
Want to, Portugal now. Oh, Portugal.
Oh,
Wonderful. Welcome, Steve. I'm glad you're safe.
Over there.
So Casey, could you walk us through your thoughts about this case?
Yeah. So this is a 78-year-old Irish gentleman who's had kidney disease for a long time, and it's become sort of progressive. But the urine is, a little bit of protein, no blood, and glucose in the urine, which is interesting in a non-diabetic. I was thinking it points more towards like a tubular interstitial process. And as Dr. Glassick brought up, I wasn't aware that it's common in the Irish population, but in general, when I see this kind of pattern of slowly progressive CKD with glycosuria, minimal proteinuria, and otherwise unexplained renal failure, you would have to think about a chronic tubular interstitial disease. So I think actually genetic testing is a pretty useful. I would have voted. I didn't vote, but I would have voted for genetic testing because the tubular interstitial kidney diseases like uromodulin or RAN mutations would be something that I would think about. What's not really consistent with that is the albumin to creatinine ratio. Well, actually, the albumin creatinine is 149, protein creatinine 648. So there is a disproportionate amount of non-albumin proteinuria, which also points towards tubular interstitial disease. I don't see any severe hypokalemia. The prior NSAID use is interesting. That does cause tubular interstitial disease if the patient has had previous episodes of interstitial nephritis. I suppose that could give him CKD, but I don't know why it would be progressive once you stop the NSAIDs. When you see glycosuria that points towards proximal tubular injury, I usually think about myeloma with tubular involvement. I don't see that, the SIP, UIP, they're all negative, free light chains are negative. So a paraprotein related tubular interstitial disease should also be on the differential. In fact, a gentleman at this age that comes in with tubular interstitial disease with glycosuria, myeloma should be, or a paraprotein related kidney disease should be considered. So I'm going to go with an inherited tubular interstitial disease as my number one, and then I'm going to also throw in a paraprotein. Obviously, we don't have any paraproteins here in this serum, but we've seen cases where you see it on the biopsy, and you have to do a pronase digestion to find out. But I'm going to go with a paraprotein related disease second, and then NSAID induced, which is sort of a low hanging fruit here, NSAID induced chronic kidney disease with the question mark of why is it progressive.
Nice. Yeah, this glycosuria really screams out. We also have a little bit disproportionate the proteinuria. I think you mentioned mostly non-albuminuria, which would also point towards tubular interstitial disease. Dr. Reen, what are your thoughts about this case?
I'm thinking tubular interstitial disease. There are some pointers towards drug-related, which is BCG might he have gotten for his bladder cancer, which was used till recently in some people, excessive use of NSAID, but the rise of creatinine is quite concerning. There is an albumin gap on his thing, and I do note many a time Dr. Wang tells us that normal free light chain doesn't rule it out. You have to do further investigation to make sure. So I think paraproteinemia, especially proximal tubulopathy, is in the differential diagnosis. But my gut feeling is that most likely it is a hereditary disease. I will keep IG4 in mind too. But my gut feeling is that it is hereditary disease, and probably genetic testing would have been more important. So we had a young man from India actually, and he actually presented with no family history. It turned out to be a tubular interstitial disease, probably familial, and he had mucin 1 abnormality. So I think that has to be kept in mind. So I'm with Dr. Gashti.
Yeah, I like the BCG. I'd read about that years ago. It's a local treatment to kind of stimulate the immune system in the bladder. But I remember reading that now that you can get a chronic interstitial nephritis. I think it's actually it's infection of the kidney itself from the low grade tuberculosis BCG. Is that right, Dr. Reen? It's actually
Yeah, you can get infection. You're right. They can get pyelonephritis and then lead to granulomas or interstitial disease.
Yeah,
So,
but it's low grade enough. They're not really presenting with it. I mean, they're not really presenting
Yeah.
with signs of infection.
I,
They're
I, I,
presenting
I think my differential diagnosis is two top, hereditary disease, and I wouldn't rule out proximal tubular disease due to plasma cell discrepancy.
Yeah, and I always like bringing up, or you brought up IgG4. I think that's always a fun one too. I mean, you know, we every week we spend so much time with a differential diagnosis of glomerular disease, and it's always fun when we get something that doesn't fit. I mean, we'll have to see what it is actually, but and there's as Dr. Gashty pointed out, there's so many things that are kind of heading us in the interstitial direction, which is not a common biopsy conference discussion. Dr. Glassick, what do you think is going on?
well, even though the patient's 78 years old, with this history of slowly progressive symptoms and signs suggestive of chronic interstitial nephritis, including glycosuria and hyperchloremic metabolic acidosis, I think I would be inclined to do genetic testing before doing a biopsy.
Interesting. Steve being in Portugal reminds me of something many years ago. But he back when the ASN, I think I don't know if they still have the CPC or not. But when Kidney Week had a CPC, he gave him a CPC with a patient with renal failure and proteinuria from Portugal, and I think of it because Steve's in Portugal right now. And the patient turned out to have transthyretin related amyloid, which, you know, getting back to this whole conversation of genetic diseases, I think is kind of interesting. And I don't know, it's not a clue, Steve. I don't think you're there researching it for this case, but you never know.
No,
We'll find out.
but even that was, you know, they have other. It was transthyretin. You know, they have heart failure, polyneuropathy, other things that go along with it, as opposed to just chronic kidney disease. You know, I don't know about. You know, it's interesting in this population of the whole ALEC2, which I know it's usually more Hispanic. But, you know, the other thing with IgG4 and BCG, which gives you, you know, what biologic false, essentially TB tests. Yeah, I would have thought they would have more in the way of pyuria in the urinalysis. You know, something more active, maybe not. If it may have happened and now it's just more kind of indolent and chronic. I mean, the issue of autosomal dominant interstitial tubular interstitial kidney disease is interesting, but it is it's a stretch with no family history whatsoever. That said, you know, we saw one young woman, again, she was much younger, who had hepatocyte nuclear factor beta 1 abnormality as her genetic tubular interstitial disease. So I guess anything's possible. But definitely, I think everything goes along with chronic tubular interstitial disease. It's just what was the cause of it. No one's really brought up the issue, and I'm sure I'll get blown out of the water on this, of just chronic NSAID use that's kind of continued to indolently progress. You know, people don't agree that actually exists, but I think it does. The other thing would be whether or not, whether or not there is some paraproteinemia here that's low grade, even though, you know, the kappa lambda ratio is 1.8, which is high, because 1.65 is normal, but it's not high for a creatinine of 2. I think it's equally as much a stretch that this person has some paraproteinemic related disease. I think the chronic interstitial disease really is a nice fit. It's just what's the cause, and I will bow out now.
You know, I think you should stay in Portugal. This is the best reception we've had ever with you. So maybe you just stay there, and we'll do all the conferences from there.
I'm good with that.
Yeah, I'd be good with that too. You know, I got to tell you, when you did that CPC, I remember this patient, they had Portugal in the stem, they had neuropathy in the stem. And, you know, if you went and did a Google search and you said neuropathy, Portugal, and renal failure, you'd get 100 hits for that. But this was long before the internet. This was a long time ago, believe it or not. I was very impressed you nailed that diagnosis.
Well, they gave me plenty of clues. The father that had the disease had heart failure as well as polyneuropathy, so it kind of helped.
Yeah, but these were early days of even knowing these things existed. Listen, take the credit. I don't give you that much credit.
You know, it doesn't happen often. I appreciate it.
Okay, that's wonderful. Dr. Rubin, do you have anything to add?
My understanding was that ATTR is not the kidney involvement is not that common in ATTR. So am I wrong in that?
No, you're right in that. but it was that day. It was that day when Steve nailed it. So, Dr. Rubin, you have anything to add?
No, everything was said.
Okay, then we're going to go to the wheel, I guess, and see what.
Like they say, Mario, even a blind squirrel finds an acorn every once in a while.
Yes.
Before you go, I just wanted to comment in the history taking in a patient like this. It's always useful to add occupational history, particularly for occult exposure to heavy metals, and also the use of herbal preparations and traditional kinds of herbal medicines because of the possibility of a aristolochic acid contamination in things that the patients don't generally regard as medications.
Yeah, and we failed to tell you that he's from Costa Rica and he works in the sugarcane field. So,
What's that?
I was kidding. I said we failed to tell you that he's from Costa Rica and he works in the sugarcane field. But
Yeah. Okay.
But I mean, no, that is relevant. Those are all very good
Okay.
points. So I wasn't being facetious. All right, the wheel. Extra long spin today. Wild card. I think this is going to be Hamoud, our second year
Man.
fellow.
That's what you get for being in clinical mood.
That's what you get for being for texting me earlier about not getting picked. It was a joke, but
Yeah. All right, Hamoud, you should be able to unmute yourself. Let's make sure you're.
Can you hear me?
Yep. All right.
beautifully.
I'm gonna share the screen again, and then I'll give you control. Remember, there's a lag sometimes. Give me a second here. Here we go. So click on the screen. There we go. Go for it.
All right, everyone. I'm Hamoud, one of the second year fellows. Let's go. Okay, so here we have two cores. It's a trichrome screen. This one looks like a cortex. This I'm not sure. Maybe it's medulla, but overall I see this blue staining maybe 5% to 10% fibrosis here. I see
So the both cores are cortex.
both are cortex. Okay.
Yeah.
Okay.
So
Yeah.
so taken together, how much do you think is scarred here?
Taken together, 15%, 20%.
No, I mean, the entire bottom core is pretty much all scarred down. The most preserved areas on the top core on the far left, I see tubules that are tightly packed back to back. I can make out a couple glomeruli on the top core, but
Do you see my arrow or
I
no?
see extensive fibrosis here, about 75%.
Okay. Yeah. Are you able to see my arrow?
Yeah, there's a little bit of a lag, but I can see your arrow. Move your arrow. Yep, we can see it.
Okay. All right. Okay. Other than that, over here,
Yeah, that's all you want to say on this. Just go to the net. You don't want to comment on glomeruli on a low power trichrome.
Okay. Okay. So here I see a PS stain. I have a glomerulus in the middle. The membranes seem okay. The most of the loops look open. Then maybe a little bit interstitium. Mesangial expansion. I don't see much cells here. Other membranes look okay. In the interstitium, I feel like the tubules are not that close, they're far apart.
Yeah, so the glomerulus, I agree. Yeah, the glomerulus overall looks fine. And then to the left there, that's some interstitial fibrosis, tubular atrophy. You could see that tubules have, thickened basement membranes. They're irregular. They're shrunken down.
Yeah. Here I see silver stain, again, a glomerulus. I don't see any holes or spikes. I don't see any breakage, if I'm not mistaken. So overall,
Yeah,
doesn't look that bad. Yeah.
normal silver stain.
Yeah. Okay. Okay, so here I have slightly higher power.
We're back to low power on a PAS.
Yeah. Oh, I was just comparing it with my initial when I was about to comment on the glom, like from the initial trichrome one. Yeah. But yeah, otherwise low power. We have another PAS. I see some cellular infiltration in the interstitium here. I don't know if you're missing gloms here, or these are part of vessels. I'm not sure.
Do you see any glomeruli?
These I'm not sure if it's what structure.
Yeah, so there's
Okay.
1, 2, 3, 4 globally sclerosed glomeruli. And this is all interstitial fibrosis, tubular atrophy that was highlighted on the trichrome stain.
Okay.
So 18 out of 28, 65% are globally sclerosed. Okay.
So David, what do you make of those? Those are fibrous crescents, right?
No, this is just the way
No?
I've been asked that 1,000 times in this conference. My answer is always the same. These are the way glomeruli die. This is
All right, well, it's 1,001 now, and so
all right, yeah.
one of these days we'll remember it.
Yeah.
Okay, yeah. And like this part is staining.
No. So they're globally sclerosed, Mahood. Yeah. Yeah. So the point of this is just to show there's extensive chronic scarring.
Okay.
Yeah, Hamoud, I already fell on
David?
my sword for this one, so you don't have to take a hit for it.
All right.
David, I
Yeah.
have a question. I have a renal pathology question. The glomeruli in this case are globally sclerosed, I would agree, but in Bowman space, there is accumulation of what appears to be a kind of a hyaline-like material, probably collagen or some other derivative.
Yeah, I agree. It's collagen.
Now, this is so-called obsolescence pattern of glomerulosclerosis. It's not the solidification pattern. So this implies that the loss of glomeruli in this patient is not due to a glomerular disease. It's due to either an interstitial disease or a vascular disease. Now, that's my interpretation. What is your interpretation of the character of the global glomerulosclerosis in this patient?
I don't think I could comment more than what you have said. It's a good observation.
Well, Agnes Fogo and I wrote a paper about this a number of years ago, and about the debate on whether hypertensive glomerulosclerosis in African Americans was a glomerular disease or a vascular disease. And the pattern of glomerulosclerosis in the majority of patients was like this. It was obsolescence, indicating that it was largely a vascular disease. But of course, subsequently, they discovered ApoL1, which is a glomerular disease, largely, and in which the glomeruli undergo obsolescence through solidification. It's always intrigued me as to whether the pattern of glomerulosclerosis offers any diagnostic value. And I must say, in this case, I think it does.
So Dick, following your teaching, I did a search of the subject a few months back, and I consulted with Helmut, Arcana, Agnes, and somehow I got the feeling that although this was an interesting finding, most renal pathologists nowadays do not consider that to be of any specific meaning. They may have to backtrack on it, but the current interpretation of the type of sclerosis somehow has gone in a different direction.
Did you include in your surveys Agnes Fogel?
Yes, I did.
And Agnes said that she doesn't think it's pertinent.
No, what Agnes said was that this actually, she quoted you and that famous paper, and but she says that nowadays most pathologists do not
Okay.
spend time in this kind of finding. But again, your point,
Well,
as always, is well taken.
Thanks very much, Dr. Rubin. That's very useful information.
Yeah, I usually don't comment on the mechanism either. So yeah, I agree with you, Dr. Rubin.
Okay.
So we have yet another pattern of injury, I guess.
Yes.
Good for you.
Now, David, can you, or Dr. Dillon, can you please go back? So what are these structures which are empty? Are these cysts? What are they?
The dislodged glomeruli.
Okay.
So here we have a higher power. You have the same sclerosed glomeruli here, and it's probably a blood vessel, if I'm not mistaken.
Yeah, arterial. Yeah.
Arterial, yeah. A lot of hyalinization. I believe it's very densely PS positive.
Yeah, severe hyalinosis.
Yeah. Here now we have a H&E stain. I don't see any glomeruli. This is mainly the interstitial area and the tubules. They're not back to back, and I see.
So this is medulla.
Okay. Okay. Right. And I see a little different staining in this area versus other slightly darker pink area. And I didn't see any cellular infiltration. So in terms of the tubules, some of them you show probably some ATN, or there's some sloughing off inside the tubules. But overall,
So what catches my eye, go over at 9 o'clock. Yeah, there's amorphous acellular deposits that are eosinophilic.
Okay.
It makes me think of amyloid.
Okay. Okay. And the interstitium itself, this like the middle
Right there where the arrow, right where you are right now is normal. And then go to the right.
Yeah.
There, yeah. That catches my eye for amyloid.
Okay.
Eosinophilic amorphous deposits.
Yeah. Okay. Makes sense. Is this the Congo red stain?
Yeah.
So yeah, we see where you were talking about in the previous slide. It seems like it's positive. These peritubular areas and the interstitium area strongly positive.
Yep. Yeah, and then so this is only positive in the medulla, deep in the medulla here. There wasn't any positive staining in the cortex.
Okay. We have a higher power view, same thing. We have a positive Congo red stain. And in the fluorescence light, we're seeing some.
Yeah, so this is not fluorescence, it's a polarized light.
Polarized, sorry. Yeah,
Yep.
and the polarized light, we're seeing the birefringence.
Yep.
So this is amyloid.
And yeah, so if you go back and forth between the previous slide and this one, that's the birefringence. Yep.
So we have immunofluorescence that is negative for
Good
everything.
thing I got medulla.
Yeah.
Yeah, so fluorescence is negative for everything. And here we have an EM, just to orient myself. So this is the urinary space, and this is the blood vessel space, the membrane. Looks okay, I don't see any deposits inside, some slightly irregular thickening over here, but I don't see any specific deposits. The podocytes, for the most part, they look okay. And
Yeah, you're right. Yeah, there was no amyloid involvement of the glomeruli.
yeah, I don't see anything out of the ordinary here.
Yep.
Okay, a little higher power. I don't see any membrane, so this is probably the interstitial area.
Yeah, so where you are, where you were was the lumen of a tubule. Those are the tubular nuclei, and then where the arrow is now is the yeah, right there, yeah.
Okay.
And so that's the interstitium.
Okay. Okay,
Is
yeah.
that normal or abnormal to you? Yeah.
Yeah. So this is probably the deposition of whatever extra
Yeah.
stuff is. Okay, possibly amyloid. Or
Yep.
Okay.
Yeah, and then we'll see that at higher power.
Yeah, so we see irregularly arranged these fibril-like material.
Yeah, randomly arranged non-branching fibrils.
Yeah. Do you have any measurement on this, or?
No, Mayo Clinic that does our processes REM, they don't give me a measurement.
Okay.
Probably between 9 and 12 nanometers.
Yep.
Yeah.
So that would be expected, yeah. So, what's your histologic diagnosis, Hamoud? Nice read, by the way.
Yeah. So we have basically randomly arranged fibrillary interstitial deposits with some glomerular sclerosis.
Yeah,
Um,
we don't like that term anymore. We don't like that term anymore. Just use the term that the Congo Red gave us.
Like, like, do you actually use amyloid?
Yeah, you use amyloid.
Okay.
Yeah, you're thinking too hard. David, did you do an amyloid A stain?
No, we sent it.
David, did you do an amyloid A stain? Yes or no?
We sent it.
Yes
to
or no,
Mayo for
David?
mass spectroscopy.
David?
No, it's so the amyloid A is a send out stain.
David,
So
let's
since
move
we're
on.
sending material out, as might as well do the mass spectroscopy.
Let's move on.
No.
All right, what would you do next? Mass spec?
Oh, okay. No, Roger, I didn't.
What would you do next at our poll number 2? Would you do mass spec? Would you do genetic testing? Or when there's a question, pronase digestion? Remember, we still don't know for sure about this whole thing because of the fact, he's 78 and he's got glycosuria and the like. So
That term was coined by Dr. Rodby this week. When there's a question, pronase digestion. That's what
Yeah,
right.
you heard it here first. I guarantee you it's going to be the title of an abstract at some point in my career.
For a few more votes. Okay.
All right. So our answer, our poll says that 70% would do mass spec. picking up on maybe David's clue. We'll see. I don't know. Maybe we should do protease digestion. I don't think that's out of the question yet. And 5% would go to genetic testing. Remember, genetic testing was one of the very early, one of the very early ones, and for a lot of people. Next slide. So, Casey, what would you do? Can you make the argument for doing one of these three?
I would do mass spec. I want to know what those amyloid fibrils are. I want to, yeah, that I would do mass spec.
Are you convinced this is not a? Are you convinced this is not a paraprotein related disease? That was number 2 on your list.
No, but if there is, that mass spec would still tell you that if there is like a IgG kappa or lambda, that would still be able to tell you that. For AL, mass spec will still tell you if there is AL. So.
Yeah, good point. It's a good point. Anybody want to argue for anything else? I take that as a no. So next slide.
I mean, if you do protease digestion and it has light chain restriction, then you may not need to go to mass spec. But you're right, mass spec will give you the answer for everything, for sure.
It's not always.
I mean,
it's hardly readily. It's not always readily available. Now, because we send this to Mayo, it is. I think I don't know if that's routine or not, but it is readily available for them. They're now doing. Now they're doing REMs.
I mean, it's hard to believe all this tubular interstitial amyloid, and I'm sure I'm probably wrong that this is an ALEC2, and it's, you know, maybe the person isn't 100% Irish, you know, and maybe it does occur in the Irish population as well. But I mean, you would think if this was a light chain associated form of amyloid, the glomeruli would have some involvement. There'd be more proteinuria than there is. I mean, this is almost all tubular. I mean, we don't know if there are free light chains in the urine or not, but I agree with, I think, Casey's assessment. This is probably beta-2 microglobulin. But, you know, I'm sure this is going to be mass spec's going to make the case on this. And it's clearly not amyloid A protein.
So let me ask you this, Steve, which one do you think it's going to be?
I think it's going to be ALEC2.
Dick?
Well, I just did a quick look at the literature, and in Ireland, the most common form of hereditary amyloidosis is, or non-AL amyloidosis is ATTR. And in fact, it's quite common in certain areas of Ireland. And I would agree, however, with the pathology here that it's LEC2 amyloidosis until proven otherwise.
And that I did the same.
I think my guess is that the immunofluorescence for LEC2 using a polyclonal antibody to LEC2 or mass spec is going to give you the answer.
So I did the same Google search and found the same thing in Ireland, that it's transthyretin. And I know Dr. Reen had brought up how uncommon renal disease is in transthyretin, but I found the same thing. It's the Donegal region of Ireland. So Dick brought that up earlier, that there was a lot of interstitial disease in Ireland. I wonder if that's before you realized it was even the transthyretin. But yeah, it is fairly common. So we've got transthyretin and we've got ALEC2. We've got kind of a mixture. So this is the drum roll. Let's wait for it, and then we're going to hand it over to Dr. Whittier, and he's going to tell us which of these two it was.
Sorry, my mute button was there. I just wanted to keep the drum roll going for a long time. But when I got this case, I've never seen anything like this except for ALEC2. And so it was really bothering me. I was, the mass spec takes 2 weeks to come back. It certainly was bothering the patient to not know what he had. But I was convinced it was going to be ALEC2. But again, I wasn't sure which was stronger. So then I thought maybe it's transthyretin. And I thought maybe that was one of the cases. And so mass spec was done, and it came back as APO4, apolipoprotein A4 type. And, obviously. So this was my first case of this.
I will point out that Dr. Friedman had put that in the chat very early. So once again, our audience is brilliant.
Very smart audience. So, how do we get to mass spec? Well, typically we've got the biopsy first, and we've got our Congo red material. Your light chain, there's no light chain restriction. You could consider pronase digestion to make sure there's no light chain restriction. We're going to do the secondary amyloid stain. Typically, secondary amyloid is glomerular, so you don't think about that as much here. And again, you're going to want to consider genetic screening in certain cases. But ultimately, just like Casey said, the mass spec is going to tell you everything. And now that we send EMs to Mayo and they do mass spec on Congo Red anyway, you could kind of just maybe skip the other ones and jump right to it, which is what we did in this case. So I want to talk just a little bit about amyloid, and this is a pretty amazing paper because it's all of the samples, and this is not just kidney. It's every sample that's gone to Mayo of 16,175 samples of amyloid, including gallbladder amyloid or genitourinary amyloid or so on. So not just cardiac, not just GI, not just renal. And I know it's kind of small, so I tried to kind of blow it up, but obviously, as you would expect, primary amyloid was the most common. TTR was the second most common. Again, not kidney, I'm talking about the whole body here. ALEC2 was actually more common than secondary, which that actually surprised me quite a bit, just because we see so much secondary here. But then again, we're in a population that may be different than send outs to Mayo Clinic. We have a lot more possibly decubitus ulcers and gunshot wound victims and people that have chronic decubitus and chronic inflammatory conditions in the inner city Chicago area. Plus probably a lot more heroin and skin popping and secondary amyloid. So that kind of surprised me a little bit, but ALEC2 is just about as common as secondary. And then you get all the way down the line and you get to APOA4 and APOA1 for that matter too. So I kind of just blew that up and looking at the percentage of almost 60% primary, TTR including cardiac is almost 30%, and then we get to this 2 to 3% range. And APOA4 and APOA1 were down here in 0.35% of all amyloid specimens sent to Mayo. And it's pretty rare out of 16,175. So pretty unusual. And then when you look at the different organ distribution, again, it's a busy slide. I'll blow up the important ones in a second. But if you're looking at all the different organ distribution, they how much was in the bone marrow and the breast and the fat aspirate and the GI tract, heart and kidney. And they also went to all the other organs as well. But I just kind of kept it at this so we could focus in on these. And each one of these is whether it's primary here or let's look at the kidney. Primary here, ALEC2 is the second most common. Secondary was third in the kidney. And then you have where ours was here, which is only 1% of kidney biopsies have APOA1. Even fibrinogen, which is mostly glomerular, was more common than that. And I haven't seen a case of that yet either. So here's all the ones of the kidney. But what was very interesting, I also thought, just like Dr. Areen pointed out, and contrary to Steve's CPC case, is that every single one of these cases that went to Mayo, there wasn't a single one case of transthyretin in the kidney. 16,100 and whatever, 75, not a single transthyretin in their kidney, which I thought was, I've seen case reports of it. So I was very surprised by that. I knew it wasn't, common transthyretin, but I thought that was pretty interesting, and that it's almost never in the kidney according to all these samples. But also APOA14 is not that common either.
Maybe it's the cardiologists are diagnosing it predominantly by cardiac biopsy, and we don't know. It's in there, but we don't know it.
Yeah. So yeah, yeah. Go ahead.
Actually, there is a variant described in ATTR. I think there was a recent paper on NTTR. Find out something VC30 or something like those patients of ATTR with a higher incidence of kidney involvement. When we are doing the mass spectrometry and genetic testing in them, that will be a good test to know when they have kidney involvement. So in that case, in that genetic variant, they have more kidney involvement. It was a couple of months ago that paper was published.
Yeah, that's right. And that's where genetic studies can help you, because it might even spare you the biopsy, that, or cardiac imaging, or even found on a routine colonoscopy or something. So so of the rare types, again, not primary, not secondary, of all these rare types, they were looking at ApoA1 and ApoA4 and how often are they involved. And, 35% in the kidney here, 33% in the heart, about 30% in the GI tract, and so on. So we are going to be seeing these, if anybody is, right? It's going to be us that sees these rare types. So how do they present? Well, it was really not described until 2016 by, again, big surprise at a Mayo Clinic. And they present just like our patient did, with slowly progressive chronic kidney disease, tubular interstitial type pattern. And this was a very nice slide that I found that kind of just localizes your different amyloid deposits. It's not always the case, but when we have up here is primary and then secondary, and here's fibrin, or the alpha fibrinogen, and those are all glomerular amyloids. Our ALEC2 is actually here, which is definitely tubular interstitial, but it's in the cortical tubular interstitial area. And then our ApoA1 and ApoA4 are actually in the cortical collecting duct in the medulla. So in our case, it was pretty classic. We had a slowly progressive tubular interstitial disease. We even had glomerular obsolescence, which was due to the tubular interstitial disease. I thought I'd just throw that wrench into the argument there. Glycosuria fits, slowly progressive CKD. It wasn't just the NSAIDs. The real question in my mind is how long this was going on. Was it going on the entire time? And it was just NSAIDs were sort of the red herring? No, yeah, red herring. Yeah, I think it's red. But that's kind of classic in our case to have the slowly progressive tubular interstitial type pattern and be in the cortical collecting duct. Of the patients that have been reported on, there's only 9. It's one series, and maybe there's occasional case reports, but they had exactly what our patient did: progressive CKD, medulla involvement, just kind of classic tubular interstitial pattern. And here's how they did over time in the 9 cases, and they all sort of slowly progressed or stayed relatively stable. Nobody really got better. So that's what I have. I mean, the other question is really, what the heck is ApoA4? And, no one really knows, but the apolipoproteins are sort of actually, they're created, or they're, synthesized in the small intestine. And they are thought to be antioxidant in nature, and also have a lipid metabolism pathway involvement. And so that's kind of the purpose of them. And no one really knows if it's an elevated serum level has anything to do with it, and why it deposits. And no one really knows quite why it's got such a predominance for hitting the cortical interstitium, or the interstitium and the medullary interstitium, not the cortex and not the glomeruli.
Bill, if I missed it, I apologize, but is there a typical age for this?
Let's see what their ages was. Yeah, so I don't think there's anything necessarily typical, but yeah, it looks like the youngest was 52 and the oldest was 81, if I'm reading that right here on their 9 cases.
He kind of fits into that phenotype.
Yep, that's right. Yeah,
we don't know if this been something been produced all along, or something that just happens when you get older, or whatever. I mean, it looks like he accelerated at the end, but that's probably just the way GFR kind of falls at the end of.
Right.
It looks that way when it's accelerating, but that's when you don't have many gloms left, the creatinine goes up quickly.
And my differential for tubular interstitial amyloid was 1, which was ALEC2. And so now I'm including ApoA1 and ApoA4 and ALEC2 in my differential, but I'm remembering that this one is more medullary and ALEC2 is more cortical.
So Bill, being a biopsy expert that you are, don't go deep enough in your biopsy. You could potentially miss this entity, couldn't you?
Oh yeah, that's why I kind of jokingly said to David, I'm glad I got the medulla. And normally we're not trying to get the obviously is what Mario's hinting at. We're really trying to get cortex, which is typically for glomerular disease. But yeah, there are diseases where they may be more tubular interstitial, but this is one that I've not really thought of that a biopsy would, that you really need to go deep, but you would here. You'd have to go deep where this picture shows.
Yeah, Bill, we're usually trying to avoid the medulla.
Exactly. Exactly.
You nailed it.
And I think, yeah, thank you. I went a little too deep, so my error got us a diagnosis. But I think in treatment, it's completely unknown. Trying to reduce the serum amyloid P component, which is present in all amyloids, has there's been, you know, some data showing that that might be effective, but the trials are kind of dying on that. I had sent this on communities, and Dr. Glassick fortunately got back to me and said that there's also some earlier data with boy, it was called desamizumab and meridosap and a couple of those things, but I haven't been able to see any follow-up on it. The clinicaltrials.gov really has, it seems to be kind of dead in the water for these kind of diseases. And, you know, I mean, this was really only discovered in 2016. And so I don't really know that we have anything out there that's effective for treatment, unfortunately for him.
Yeah, well, hopefully he'll outlive this, but the way his renal function is going, he may not. But I tell you, it caught a lot of us off guard. Even with all the clues, we still caught us off guard. And I mean, that's why we do these things. You know, Dr. Rubin's been making the point, you know, let's just be careful and not go too far with avoiding biopsies. And this is a good example. And this is, you know, this is an example where genetic testing wouldn't have made the diagnosis either, right, Bill?
It's a non-genetic amyloid. That's correct.
So the only way we're going to make this diagnosis really is the way you did it, correct?
Is going too deep and getting medulla.
And you went very deep into the discussion.
Bill, quick discussion, and you know, usually when we see glycosuria associated with chronic interstitial disease, we think of cortical with proximal tubular involvement, not medullary disease. When we see patients with diabetes insipidus or nephrogenic DI, then we think of collecting duct disorders. This patient had glycosuria, and there was no clear history of massive polyuria or hypernatremia, anything to suggest nephrogenic DI, despite all of the evidence that this is a medullary disease. That's a bit odd. I suppose we could explain the glycosuria by a marked heterogeneity of the single nephron GFR. You see, when there's only one glomerulus providing all the glomerular filtration for the whole kidney, the filtered load of glucose can overwhelm the tubule, and you can get glycosuria, even without an abnormality of proximal tubular function. It's just that massive glomerular hyperfiltration produces glycosuria. But I'm having trouble in this patient looking at the biopsy, where we didn't see a few normal glomeruli that are huge, showing, you know, compensatory hypertrophy. But this is really an educational case. I mean, massive medullary amyloidosis without anything else but just a progressive decline of GFR. Fascinating.
It was also perivascular in the article.
Yeah.
Sorry. So there was, I didn't want to forget about that part. And David, was there vascular involvement that we saw? Are you still there?
No, on the medulla.
Okay.
But no hypertension.
Yeah, his barely, right, exactly.
Mario, you had another point?
And typically with classic, I'm sorry, Mario, real quick, with classic amyloid, we can see an autonomic insufficiency in low blood pressures, but in this case, you would think maybe if it's periaortic and it's constricting, maybe there'd be hypertension.
I'm just curious, but did you do a cardiac scan of any kind? Because these patients do get cardiac disease as well, don't they, Bill?
We did, yeah. I sent him to our infiltrative cardiology specialist here, and he's still on the way to see them. He's seeing them, but they're doing the workup now. We don't have an echo yet, but that workup, even though there's not a treatment for it, and there is a treatment for the transthyretin one, even though there's not a treatment, maybe getting him on, you know, he has little heart failure, maybe getting him on earlier heart failure meds might actually help prolong his survival. You know, compared to, you know, maybe he needs a little aldactone or he has a reduced EF, even though he's not symptomatic. And I thought that was an important part, that might be one of the only things that can really, hopefully, get him to live longer.
Right.
Now, Bill, he's a cardiologist at BU that is doing a lot of work on TTR and the heart with newer imaging modalities. I'll try to find his name. I recently heard a lecture of his and give it to you. That might be helpful. And what I wanted to point out is that a certain individual Today in the ASN communities preface this by saying, I'm not a kidney biopsy nihilist. So slowly but surely, I think he's changing.
Yeah,
which
that's right.
is welcome addition.
Great, Mario. Good point.
I
Keep
think
this slide up for a minute, Bill, so we
Sure.
can get this embedded in our memory. Of
Yeah.
all of the amyloid types, only a few are non-hereditary. ALEC2, the APO4 and APO1, and the AL are non-hereditary. Everything else on this list is hereditary, correct?
Yeah, I think so. I'm not sure about ALNS, but you may be right. But yes, I think so.
Well, I mean, I'm going to remember this is when you have a patient who has no family history and doesn't have a ancestral link like Spanish orientation in ALEC or Irish in ATTR, you should think of the non-hereditary amyloidosis, and they can only be diagnosed by mass spec and a biopsy. It's useless to do genetic testing in that situation.
Yeah,
I learned, I mean, that's one thing I'm going to take away from this session today is here's an example where genetic testing is not the way to go. Biopsy is the way to go if you want to make a diagnosis.
I can't believe that I've been able to teach Dr. Glassick something. I don't think that's
no, this is very educational.
I'll tell you what, I'm taking.
I'm wondering if Dr. Friedman can comment on what made him bring up this type of amyloidosis. What were we missing that he didn't miss?
Can you open his mic, Pravir, if he's still on?
Oh, he says, my partner has a case.
I think, Dr. Whittier, you did post this case on ASN community.
Yep, I did. Well, honestly, it was rare. I was at a loss.
Nobody answered. If I remember, nobody answered.
Yeah, there was one person that kind of pointed me in the direction of the serum amyloid A protein, possibly treatment for that. Now, in this particular patient, he's too far gone, I think, to have any benefit from treatment, even if there was one. But for example, if Rituxan worked for this, would I give him Rituxan? I mean, that's a whole separate discussion. But there wasn't really a good treatment available for this disease anyway, and that was something else I learned. And Dr. Glassick had emailed me separately talking about a couple of the other promising trials that really have unfortunately gone nowhere, which usually means that they kind of ended dead in the water.
Bill, who you're kidding? You give
I presume this protein is made in the liver?
It's made in the small intestine, according to the article.
Ah, okay.
Yeah.
So even liver transplantation wouldn't do anything.
Dr. Friedman,
it's made in the small intestine.
Yeah, and honestly, I didn't know the small intestine made anything.
Dr. Friedman, did you have any comments?
Can you hear me?
Yes.
Yeah, no, it was just non-hereditary tubular-interstitial amyloid, and my partner having a case. That was pretty much the tip-off for me.
Yeah, you're being humble. You often say some really smart things in this conference, but that's great. What did I learn from this conference? That was when in question, pronounced digestion is not the answer. It's now when in question, it's mass spec. And right. I think biopsy and mass spec, and kudos to everyone for all the comments. What a great case. I learned a lot. Yeah. Even Dr. Glassick learned a lot. So it's a win-win. We will not have a case next week. Thanks everybody for joining us and being so attentive. Thanks, Bill. It was a great case and a great discussion.
Yeah, great case, Bill.
Thanks everybody.
We'll see you in 2 weeks.